So we're doing heart physiology today. First off, we're going to talk about the internal electrical system of the heart. Your heart has its own self-excitatory neural tissue, so it can sit there and beat even if you're brain dead. So if I was to cut the nervous connection between my brain and my heart has its own little nervous system in it that can keep the heart beating on its own. That's its pacemaker. It's going to have a couple different parts to it. It's going to have the SA node. It's going to have the AV node, the AV bundle, aka the bundle of His, the bundle branches, which turn into the Purkinje fibers. So I want you to be able to follow that flow. SA node, AV bundle, bundle branches, Purkinje fibers. Your SA node is going to be your primary pacemaker, and that will set your heart rate at 75 beats per minute. So 75 times per minute, the SA node fires. And what happens is the AV node will pause it for a second, and then the electrical impulse will get sent down into the AV bundle. It'll continue down into the bundle branches, into the Purkinje fibers. The reason why this AV node will pause the impulse from the SA node for a split second is, if it doesn't, my atria and my ventricles will contract at the exact same time. So my SA node fires, this pauses the electrical impulse for one moment, so my atria can contract, give it a little shot of blood into my ventricles, then the impulse gets sent off to my ventricles and my ventricles can contract completely. My SA node fires 75 times per minute, but me sitting here right now, I typically have a resting heart rate of about 60. The reason for that is that my brain is still connected to my heart. So my parasympathetic fibers are still connected to my heart, and what they do is they can decrease my heart rate. Alright, so my parasympathetic fibers will be there to decrease my heart rate. Sympathetic fibers also connect to the heart, and they can be there to increase your heart rate if need be. When my internal conductive system of the heart is firing, there are specific events that occur. An ECG, an electrocardiogram, can record these, and when you read it, you can pick up numerous things. So we're going to see a couple features of our ECG. First thing is our P wave. So we have our P wave. This is the P wave right here. Isoelectric line, which is this flat line here. So the start of the P wave to the isoelectric line is this right here. Next, we get our PR-PQ interval. It's going to be start of the P wave to the start of the Q deflection, so PQ interval. Our PR segment is going to go from the end of the P wave, alright, to the start of the Q deflection. So a segment is going to be a flat spot, a wave is going to be a bump. So here's our segment right here. End of the P to the start of Q deflection. Here's our Q deflection. Our QRS complex is going to be from the start of our Q deflection all the way until we have this S return to the isometric line. We get our ST segment, which is going to be the end of the S deflection until the start of the T wave. Once again, our flat spot. And then we get our QT interval, which is the start of the Q wave, Q deflection, until the end of the T wave. And then we get our T wave, our last little blip here. So what's happening with each one of these? Our atrial depolarization occurs from the P wave. This is going to be the neural tissue is depolarizing. It causes the atria to contract. Our atria are thinner layer of muscle. They don't contract as hard as the ventricles, so they don't get as much electrical impulse. Ventricular depolarization is our QRS complex. This is much larger. Why? Because the ventricles are contracting. There's a lot more muscle there. There needs to be a lot more electrical activity to get all those muscle fibers to fire. Then here we get our ventricular repolarization, which is going to be the ventricles resetting. If you notice, there's no atrial repolarization that you see here. What's happening is the atrial repolarization is actually getting hidden by the QRS complex. So P wave is going to be the SA node firing. Our PR segment is going to occur from the AV node delay, all right? Then this is going to be our ventricles contracting, so it'll be our Purkinje fibers sending the electrical impulse, and this is just our repolarization. So, SA node fires, we get our P wave. It spreads throughout the atria. AV node pauses it for a second, all right? We get our QRS complex, which is going to be our Purkinje fibers causing the ventricles to contract. Here's a normal ECG. These are some abnormal ECGs. Within the ECG, you can see is there some sort of problem with the electrical system of the heart? Are the muscles firing too fast or too slow? Are they separated out? You could pick up all kinds of different. Are the ventricle and atria contracting together, or is the atria not contracting? Or you can pick up all kinds of stuff from our ECGs. They are very, very powerful tools in medicine. So next we're looking at our heart sounds. Let's check this chart out. At top we have our ECG. Next we show our heart sounds, so sound 1, sound 2. Here we're showing blood pressures within the aorta, which is this green thing, within the atria, which is this purple line, and within the ventricle, the atria, which is purple, and within the ventricle, which is this blue line. And here we're showing the blood volume within the left ventricle. Down here it tells us what valves are open with our AV valves, and here's our aortic and pulmonary semilunar valves, which valves are open. This represents all valves being closed, and then this tells us which phase. If you can read this chart, it will be very, very helpful to you, and you will be able to do a lot better on the test if you know this chart inside and out. So first off, our heart sounds, lub-dub. First heart sound is the ventricle contracting. When the ventricle contracts, pressure builds in the ventricles, and when the pressure builds in the ventricles, it shuts the AV valves. Next heart sound is the semilunar valves closing, the aortic and pulmonary semilunar valves. What's happening? The ventricle is relaxing, blood is trying to regurgitate from the aorta or the pulmonary trunk into the ventricles, and boom, those semilunar valves shut. We have systole and diastole. Systole is contraction, diastole is relaxation. So with our cardiac cycle, we're going to have it broken into our three main phases: our ventricular filling, our ventricular systole, and our isovolumetric relaxation. So let's go through this. We have our ECG. P wave occurs. When the P wave occurs, SA node fires, atrium contracts. Pressure in my aorta is declining here. When my P wave fires, pressure in my atria blips up. Pressure in my atria is greater than pressure in my ventricle, so blood is flowing from my atria into my ventricle. So this shows the amount of blood in the ventricle is increasing. This tells me my AV valve, my atrioventricular valves are open, and my semilunar valves are closed. It's represented here. It shows that the atria are filling the ventricles. QRS complex. At the very tip of my QRS complex is when the ventricle begins to contract. When that ventricle begins to contract, the pressure of the ventricle rises above the pressure of the atrium. It causes my AV valves to shut, and my pressure is building here. All right. When those AV valves shut, my blood inside of the heart is at a constant level, and we refer to that as the end diastolic volume. It's the amount of blood in the heart after diastole, after the ventricles have been relaxed. So that's the most blood that will be in the heart. If you notice here, my AV valves are closed and my semilunar valves are closed. So we call this isovolumetric contraction. Iso is in the amount of fluid is the same, volumetric is in volume of fluid, and contraction. So my ventricle is contracting and the pressure in it is building until it reaches that of the aorta. Once the pressure of the ventricle surpasses the pressure of the aorta, what happens is ventricular ejection. Blood leaves the ventricle into the aorta and pulmonary trunk. So the ventricle is still continuing to contract, and it is pushing blood into the aorta. At this point, my ventricle is starting to relax, and the pressure in the ventricle drops down. Okay? When the pressure in the ventricle drops below the pressure in the aorta, the semilunar valves will close. Alright? Pressure in the ventricle is still higher than pressure in the atrium, so blood is not entering the ventricle. So we call this our isovolumetric relaxation. Alright? Pressure in the ventricle is dropping. My blood level in the ventricle is the same, isovolumetric, and all the valves are closed. Why? Ventricular pressure is higher than atrial pressure, but it's lower than my aortic pressure. Alright? Once the pressure in the ventricle drops below that of the aorta, my AV valves open, pulmonary valves are still closed, and the ventricle starts to fill up with blood. Alright? When the ventricle contracts, this whole part right here, blood is leaving the ventricle. So blood is leaving the ventricle. So we have our end diastolic volume, we have our ventricular ejection phase, so blood is leaving the ventricle. AV valves are closed, semilunar valves are open. So blood is leaving into the pulmonary trunk and into the aorta. Once the heart is done contracting, once the ventricle is done contracting, we have our end systolic volume. That's the amount of blood left in the ventricle after it has contracted. Alright? If we take end diastolic volume and subtract the end systolic volume, we get what is called our stroke volume, which is typically about 60 milliliters of blood. Here we have something called the dicrotic notch. The occurrence of the dicrotic notch happens because the aorta is an elastic blood vessel. So when the ventricle contracts, it pushes out all this blood. The aorta expands to accept the blood. When the ventricle relaxes, what happens is the blood tries to regurgitate into the ventricle. We have our pulmonary semilunar valves. It's not going to allow it to happen. But what will occur is the aorta will actually continue with its expansion, and since it's elastic, it recoils. So it'll send the blood on its way. So when it recoils, it gives it a quick shot up in pressure, and then the blood goes on its way. Blood will always flow down the pressure gradient. So wherever pressure is higher, it'll go from the higher pressure to the lower pressure. So, cardiac output. Cardiac output equals heart rate times stroke volume. That means we are going to be measuring the amount of blood leaving the heart per minute, basically. You can increase the cardiac output by increasing stroke volume or by increasing heart rate. Your stroke volume is going to be regulated by preload, contractility, and afterload. And your heart rate is going to be regulated by your autonomic nervous system, chemical regulation, and other factors. This is straight off your study guide. Use this to fill that in. Okay, the preload is going to be the pressure that must be overcome to allow blood into the ventricles. That means, are the ventricles going to easily expand to allow blood into them? Contractility. How hard or how vigorously will the ventricles contract? Alright? The harder they contract, the better we're going to be able to push out blood. There's something called the Frank-Starling law. It states the critical factor controlling stroke volume is the degree of stretch of cardiac muscle cells immediately before they contract. Think of it this way. The more blood the ventricle fills up with, the more vigorously it will contract. Kind of like pulling a rubber band. If I pull it just a little bit and snap you on the arm with it, you won't care. If I pull it back a whole bunch and snap you on the arm with it, you're going to care. So the more the ventricle fills up with blood, the more those muscle cells get stretched out and the harder they're going to contract. An afterload is going to be the pressure the blood must overcome before it can be ejected from the heart. So right here, this isovolumetric contraction, how much pressure does it have to overcome to get out of the heart? With regulation of heart rate, we have our autonomic nervous system. So we have sympathetic versus parasympathetic. So you get a loud noise. The loud noise gives you a sympathetic response. Somebody upsets you, you get a sympathetic response. It's fight or flight. You get angry with somebody, your heart rate increases, your pupils dilate. You're getting ready to go fight somebody or go run away from something. So fight or flight. Rest and digest. Thanksgiving dinner, a couple beers. You're relaxing, watching some football. Heart rate's down. You're just relaxing. Let me go back, sorry. Alright, chemical regulations. We're going to have epinephrine and thyroxine and calcium ions. Epinephrine and thyroxine are going to help to increase heart rate. And then other factors such as age. As you get older, it's going to change your heart rate. Male versus female, exercise, and body temperatures. Okay, so this is showing preload. How hard is it for these ventricular walls to stretch out and relax and allow blood to enter them? Afterload, how much pressure do we have to overcome in the aorta and pulmonary trunk to pump the blood out of the heart? With our embryological development, basically what I want you to pull off of this is I want you to know what the foraminal valley is and the ductus arteriosum is. The foraminal valley is a shunt that is connecting the right and left atria to prevent blood from entering the pulmonary circuit in a fetus. The ductus arteriosum is a shunt connecting the pulmonary trunk to the aorta, preventing blood once again from entering the pulmonary circuit. That's it.